Severely damaged knee joints, most often as a result of osteoarthritis or trauma, can cause intense pain and interfere with walking and everyday life.
In some cases, total knee replacement surgery is recommended to help relieve severe pain and restore function.
Today on Health Talk, Dr. Nicholas Polifrani, Chief of Orthopedic Surgery at Norwalk Hospital, will discuss recent advancements in total knee replacement surgery, which have resulted in high success rates.
These advances have reduced post-surgical pain and improved the already high success rates for knee replacement surgery.
Stay tuned for an interesting show. We're up next.
Hello, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Today we're discussing advances in the total knee joint replacement surgery.
We welcome our guest, Dr. Nicholas Polifrani, back to our show. Dr. Polifrani is Chief of Orthopedic Surgery at Norwalk Hospital.
Welcome back.
Thank you.
Great to have you here.
Thanks.
So Nick, now we're talking about the knee.
Yes.
And maybe again, people have heard about knee replacement surgery, and it's really become much more complex than that, isn't it? There are many different procedures. Walk us through it, if you would.
Well, this is a model of a different type of a knee replacement that we have. The knee joint is a hinge joint. It's a relatively simple hinge joint, but a complicated hinge joint. It has ligaments and tendons holding it together. But the basic problem that we developed during arthritis is that the surfaces break down. The cushion that's attached to the bone when we're born wears down, and for some reason we weren't given the ability to heal. So it becomes arthritic, painful. The knee joint has three surfaces. It has an inside surface, an outside surface, and a patellofemoral joint. Three separate surfaces all within the same joint. We now have the ability to do individual replacements. Those are called partial knees. Patients always ask me, am I a candidate for a partial knee? Many times it's an isolated injury where one part of it, one of the surfaces is worn, either the inside of the joint, the outside, or the kneecap joint. But many times the injury is so severe that we end up doing a total knee replacement. But one of our big advances is we're now using a robot to do a lot of these surgeries, robotic surgery.
So tell us a little bit about why does a robot make a difference?
The key to all the success for most of these mechanically based orthopedic procedures is accuracy. Getting the alignment just right, getting the alignment right for you or for somebody else, for the individual patient.
And that helps with pain and longevity of the...
Longevity, pain, the function of the joint. We try to restore the function of the joint to the patient's normal anatomy. Many times, most of the time when we're doing surgery, the joint has been so deformed that restoring it to regular alignment is at best a guess, unless you have a computer assisted.
So how does that work? So you take... Well, my understanding, you take a CAT scan of the joint and you're able to upload that information to the computer, and then it can help model the replacement?
A three-dimensional image is produced. It's modified into the software of the robot, makes a three-dimensional image, exact components and sizes of the patient's body, and then we plan the operation around that three-dimensional image, the position, the rotation, the size, to create the best fit possible.
Now, based on the x-ray, you're able to determine if with a partial knee replacement or a total is necessary, or does the computer help you with that too?
That's all done before. We try to make a decision. Sometimes we'll go in to do a partial replacement and end up doing a full replacement anyway, because either the CAT scan didn't show or the disease within the joint is just much more severe, so then we'll do a complete knee replacement instead.
Now, the computer doesn't do the surgery, does it? Say a couple of words about how that helps you in the operating room.
The robot doesn't do the surgery, and there are very successful surgeries done without these devices. Surgeons that are high volume do these cases all the time. We get really good alignment. Our x-rays look really great. But this is just an assurance that you're not going to look at an x-ray every 10 or 15 patients and go, gee, I could have done this, I could have done that differently. This almost guarantees you're going to put it exactly where you want it. The computer works by using an instrument. In the hips we use a different instrument, but on the side of the robot can be a burr or a saw or a reamer, depending upon what operation we're doing.
And that really is, for the folks at home, really is a saw or a reamer.
It really is.
Yeah.
We are actually doing the procedure. We're not leaving the room and letting the robot work. The robot does not move. We move the robot. The robot is simply an amazing guidance system. One of my patients asked me, Dr. Polifrani, why don't you use lasers like the contractors do to make it accurate? This is our laser. Mm-hmm. This is our laser of the future, because it makes it accurate within 1/100 of a millimeter, which is very, very small.
In addition to advances in using the robot and the computer, have there been advances in the actual surgery and in pain management around the time of surgery that have made a difference for patients?
It's all part of the same package. We prep the patients. First of all, the patients come in now aware of what we expect of them to do after the operation. They know what they're going to expect as far as pain and what they'll be doing the first couple of days. That's very important. We've been telling patients the most important thing we're going to do for you is empower you to get up the first day of surgery, to know what to experience. And when Cy Sims said, an educated customer is the best customer. So that's the big thing, is preparing them. But then we modify their pain through multimodal pain management. We don't use heavy narcotics. We use a lot of different little medications, injections of numbing medication, all means to decrease the patient's postoperative pain.
And I just want to give a little advertisement for that. We've had some of your patients on the show,
yes,
and they tell us that they are having joint replacement surgery with almost no postoperative pain.
It does diminish. It is amazing. Many of the patients don't experience discomfort. They call it discomfort. They call it mild achiness. A lot of the total hips and knees now go home taking Tylenol.
Because the thought of it is so painful. It is. Orthopedic pain, fractures are so painful.
But if you modify the pain in that first 24, 48 hours, it really negates the pain threshold for the rest of their recovery.
It's so important. It seems to me that earlier in my career, knee replacement often caused a lot of pain for patients, often worse than hip replacement, and it was a more challenging experience for patients. And to have this revolution come about has just been amazing for patients.
I never wanted to make rounds of my total knee patients because they were very uncomfortable. We use local blocks by the anesthesiologist now to completely numb the inside of the knee, so the patients don't even have any pain that first day. Very, very important, because then the pain never really overwhelms them. They have it, but it doesn't overwhelm.
And this is not a new discovery of a drug or anything. It's really taking many drugs and approaches and putting them together.
Many attitudes.
I want to make sure we have enough time for this. You brought along a series of X-rays on 3 different patients, and we'd like to bring those up. And maybe you could just walk us through what you did for all these folks and what the X-rays told you. I think it should be interesting for folks at home.
Well, this is just a pre-op of a patient. The knees look relatively normal, slightly narrowed on both sides. The next slide, please. Next slide. So this is what we did post-operatively. This patient had purely kneecap pain. This joint right here, purely in the kneecap. And we now have the ability, we've had the ability to do this operation before, but it was very difficult to get reproducible results. With the computer-guided surgery, with the robotic-guided surgery, we can accurately position and plan where to put this component.
So that white thing on the left knee,
that's the component.
That's a prosthetic.
Can you show
patella?
the next slide?
Yeah, the next one.
That's what it looks at from the side. We're really just replacing one of the compartments of the knee. The next slide, please.
The next one.
And this is what it looks like from what we call the kneecap view, looking straight down with the kneecap
So the
tracks.
patella is natural. The actual
the patella is still there, but we actually resurfaced the patella with a little plastic button that goes between the metal piece and that. So all her pain was from her patellofemoral joint, and this allows it. It's very difficult to put it exactly where you need to, but with the robot, you can put it perfectly.
Wonderful.
That's spectacular.
And the next slide is someone. We can show the next.
Bring up the next one. It sounds like that patient was spared having a larger surgery than she really needed because of these advancements.
Absolutely, because they able to do a partial replacement is you keep all the natural cruciate ligaments of the knee joint, less intervention.
Here we have the next patient.
This patient, if you look closely on the his left knee, which is on the right-hand side of the picture, there's a hole in the lower portion of his thigh bone. Can we see the next slide? You sort of see it. It's not an arthritic knee. This gentleman actually had avascular necrosis of his knee joint. The bone died on the inside of his compartment, making it painful in just one place. Next slide. But he also had a bad kneecap. So when we got in to do the surgery to replace just that single part, his kneecap was bad. So instead of doing a complete knee replacement, I replaced his kneecap and the inside compartment. Next slide, please. That shows where his kneecaps preoperatively were off to the side and arthritic. And then next slide. And this is what it looks like. It's actually a very space-age looking x-ray. So we did two operations in one. There was the patellofemoral, or the kneecap replacement. That's that big white one in the middle. And then the inside compartment is a metal runner and a titanium tray, and then between that is a plastic surface. And that replaced his diseased bone.
And we're seeing some staples there, too.
Yep. And I just saw him back, and he's like 3 months out already. He's only 2 weeks out. He's feeling great.
Fantastic.
Next
slide.
patient. So sometimes we can't do that, and the patient's anatomy is very badly damaged, or it just collapsed into a certain position that you can't correct with a partial knee replacement. So then we would do the next step, which would be a full total knee.
Okay, well, here we are.
This gentleman came in at 45 years of knee pain after being hit by a car and very, very badly damaged. Was in the hospital for 6 months. This is the side view. The joint is completely gone. He had no motion of his knee. He barely could move his knee 20 degrees.
Wow.
So, and this is also his kneecap, which is all rotted away on the side. So what we did is I did a robotically designed computer surgery for him. And I was able to balance his ligaments and get his knee moving. He came into the office with almost full extension of his knee and 90 degrees of flexion. He hasn't bent his knee 90 degrees in probably 35 years.
Wow.
And
what a wonderful
the
result.
reason I show this is this is all done with the robotic arm holding the saw freehand. The robotic arm is controlling where we cut, or we're using the saw based upon our preoperative program.
Nick, do you think you could have achieved the same results if you didn't have the robot available?
No. And I say that because I've been using the robot. Before I was using the robot, I would say yes. But this gentleman, I was able to change my plan intraoperatively 3 or 4 times to match his different anatomy. And it's done because the brains of the computer is smart enough that as you put the patient through range of motion, it picks up stresses on the inside and the outside of the joint. And it tells you you have to release it here. And the computer can make a cut that's 1 degree different. You can't do freehand. You just can't do it. It's impossible to cut that way. And you could change it until the fit is perfect. And it's, for him, it was a long surgery. It was a terrible knee, one of the worst things I've ever done. But it was having like a second brilliant surgeon in the room with me, helping to do the surgery, guiding the whole process through computer, through three-dimensional guidance.
That's actually a wonderful place to end on, having a second brilliant surgeon in the room, helping patients, and we thank you for all your help for patients.
Thank you.
Thank you for coming on the show.
That is really very, very exciting stuff.
Really
I really
remarkable.
love it, especially as my joints get older. We are all out of time for today. Andrew and I would both like to thank Dr. Nicholas Polifrani for joining us on this fabulous edition of Health Talk.
Please do send us your questions and comments to healthtalk@wchn.org. We really look forward to hearing from you.
Thanks for watching.
Be well. See you next time.